Thank you. So for this panel, we have only 15 minutes. So I'll be trying to be short, and let's keep discussion short so that we can discuss upon the important points. So in the management of first line, Venival sir has given a brilliant talk where he has shown all the points which are related to management of the selection of the drug, toxicities of various drugs. So all these things are very important. So I will start with this slide where we see that there are various testing modalities for ALK. So starting with Rohit boss, Dr. Rohit, how do you test ALK most commonly in your practice?
So most commonly, ISA is the method by which we test, and the second most common is NGS.
Yes. So I think most of the panelists will agree that ISA is usually the preferred way, and we all test with IHC. NGS, even if we have very good quality NGS access, anybody would like to not do ALK IHC in the practice? Because IHC test can be available within next 1 to 2 days. That is why I think most of us would like to do ALK IHC, and at the same time we are sending for NGS. Okay. So just to discuss, since we are doing NGS and IHC as well, so any difference in selection of the treatment based on ALK variant translocation? Tarachan was?
No, if the patient is ALK positive, then hit the hard first.
Okay. So actually there is no difference in the treatment as highlighted, but there is difference in prognosis. Dr. Ajay, from the impression of Crown data, from Sir's talk, so Venival Sir's talk, what is your impression? How do you keep that in mind while selecting the first line TK in your practice?
Okay, so in this Crown trial, in last few years, we have rarely seen this type of hazard ratio with any trial, especially in metastatic setting. There was 72% reduction in risk of progression or death in this trial. And the important thing is that majority of patients, 25% patients were having brain mets. And this drug is especially effective in these subset of patients. So first choice will be definitely lorlatinib.
Okay, so it seems that the choice for the drug is shifting from other drugs to lorlatinib with the availability of data. And this is the ESMO 2022 data, which has also been presented with the slide, which has also been highlighted by Venival sir, which showed that at 3 years, patient who didn't have brain mets, only one patient developed brain mets. So that is very, very impressive, actually. That is very important. Dr. Ashim Samar, sir, this slide where we see that a patient of follow-up for 3 years, the patient out of so many patients, that is, you can see 112 patients on lorlatinib, only one patient had progression in brain met. So does this interest you, this type of data?
Only one patient progressed.
Only one patient progressed in brain in the patients without baseline brain metastasis.
So that means this drug is very effective.
Yes.
So preventing the brain mets.
Yes.
So penetration is much more than we expected. Right?
Yes. And we all know that ALK positive patients, they progress in the brain. And this is the site where if patient 1 progressed, it is very difficult to improve the performance status of the patient. That is very important. It is not that we can use first generation, then second, then third. What is the problem is actually after one treatment failure, around 30% patient drop out. They cannot receive any line of treatment because their performance status had deteriorated so much that they cannot receive further line of treatment. Sir, do you agree?
Yeah, definitely. So this is definitely a potent drug, and we are talking about hazard ratio of 0.02, 0.12. Never heard of such hazard ratios. So definitely it is effective. So there is a protective effect also for brain metastasis. So it is effective in both ways. If there is brain metastasis, then also about 70% CR rates, never heard of. And if there are no brain metastasis, then also it is very effective. So it is a good drug, though side effects are there. We will be discussing about side effects.
Yes. So as you told that there are some important side effects, some have been covered by Venival sir also. So the important part is that there were no grade 4 CNS adverse effects. And most of them, as we can see the graph, they are reducing with time and predominantly grade 1.
CNS side effects are very tricky actually. So it's at times become very difficult whether there are brain metastasis or like mood swings, cognitive disorders, or the classical, the speech problems are there. Patient finds difficult in getting the words for the things. So at times it becomes very difficult to say. So at times we get the MRI also done and it comes out to be negative. So it is a tricky for cognitive. Definitely there are lots of CNS side effects are there about, I think 20-30% if I'm not wrong. So there are there.
Yes. So Benival sir, in practice, if patient is on lorlatinib and presenting with some CNS symptoms, for example, sir highlighted that there might be difficulty in selecting the words for the patient. Do you would like to do the MRI, or you would like to wait? How do you decide? Because this is a tricky situation. Whether to wait and patient might deteriorate if there is a brain mets, whether you would just hold the TKI for some time and let's see. How do you decide in your clinic, sir?
If patient has this type of symptom, then we straightforward hold the TK for some time. And if we do MRI or not, it depends on the patient's condition. The patient is have good performance status and only some forgetfulness or only have difficulty in articulations without any other focal symptoms. So we can wait for some time. And if we hold the drug, then there is improvement in after 2 or 3 days. So we can hold MRI for 2 or 3 days. If there is still deterioration, then we can go for MRI.
Okay. So as sir highlighted, there is importance in clinical judgment. And if the symptoms are such that patient is also having nausea, vomiting, and significant dizziness, I think we all will agree that we need to do MRI or any imaging of the brain to see whether it is actual progression. So yes, CNS adverse effects are there, but they are usually mild. And what is the important point which needs to be highlighted? Only 2 patients required discontinuation of lorlatinib permanently due to the CNS adverse effects. So these may be common, but these are not usually leading to a very significant difference. Other points, management of hyperlipidemia. So Tarachan boss, hyperlipidemia is very, very common in the patients on lorlatinib. What is your strategy to check the lipid profile? Do it at the baseline or when you repeat? What is your strategy?
Actually, whenever the patient developed hyperlipidemia, I start with the rosuvastatin 10 milligram. And yes, I had only 2 patients on lorlatinib, and both of the patients had hyperlipidemia. That was resolved within 2 months of rosuvastatin 10 milligram OD only.
Okay. Okay. Anyone practices any different strategy? Vijay sir, your take on management of hyperlipidemia? Okay. And also, sir, if there is associated hypertriglyceridemia, do you add fenofibrate or you go ahead with single agent Rusuvas?
So if that comes out to be grade 3 on CTC, yes, I would add, all else no.
Okay, sir. Okay. Thank you, sir.
I think one thing which again complicates matter at something with is the CNS side effects, especially if the patient has also received radiation previously, then that also comes into the picture. Post radiation changes, lorlatinib induced cognitive, and even the progression. I think one thing which also helps in that sense is what was the location of the previous site of the metastasis. Though it is not that the mets would increase at the same sites, but it is very unlikely that if you start lorlatinib, most of this cognitive decline would come within early phase of the treatment rather than in the late.
So these are very important points actually to differentiate the site of the location of the lesions, the time of onset. That's Benival sir also highlighted in his talk. These come usually early in the, so these help in deciding why and when. So these are the dose. This again, Vijay sir has highlighted about the lorlatinib related CNS effects, and around 24 patients require 1 or more dose modification as a result of CNS effects. And 15 of these experience resolution of the CNS symptoms very shortly, and medium time to resolution was only around 12 days. So it takes some time, 10 to 12 days for complete resolution of the symptom. And most of the time, we might require dose reduction. That is, so instead of 100 mg, we might need to come down to 75 milligram. That is how we manage the CNS adverse effects, because these are important and these lead to deterioration in the quality of life if not well managed. So this is a adverse effect which is specific to this drug, and we need to learn to how to manage it. And this is the guidelines for, you can see the step 1 reduction, 25 milligram. For grade 1 also can be considered depending on the symptom and everything. So I would like to take opinion of Dr. Amit Agrawal sir here. Sir, if patient is having variant 3, so what is your suggestion? Patient has done NGS and you found ALK variant 3 fusion. So any suggestion for the treatment, which drug to choose, or any co-occurrence of P53 will change your suggestion for treatment, anything like that?
We know that the variant 3 don't respond much to crizotinib, so the choice definitely will move towards lorlatinib. But there is no such information available where we have seen that the lorlatinib for variant 3 will not work. So I think the choice always remains lorlatinib when we have this option available. But regarding P53, once we have that, it comes with the poor prognosis. The response may go down further. There is a possibility, but the choice remains the same. We do not change based on this variant calling as of now.
Okay, thank you. So that is another very important point, which has highlighted by sir, that though the choice usually doesn't change, but we will definitely choose to avoid at least first generation TKI wherever feasible. Sometimes it might not be feasible, but most of the time we try to utilize the same. And let's see some resistant mechanism with ALK TKI, because these help in selecting the treatment sometimes. And we know with crizotinib, there is usually ALK-dependent resistant mutations are there. L1196M is very common one. And apart from this, the C1156, G1202R also comes into the picture. But it is not so common after crizo, but more common after second generation TKIs. This is what they are. If we see with lorlatinib, there are some resistant mutations which come up. ALK independent resistant mutation mechanism is NF2 loss of function. While with ceritinib and alectinib, MET amplification is an important mechanism that needs to be considered, because there is a targetable mutation as a result of resistance to these drugs. While we see with the data, the PFS by lines of prior TKIs, if you see, if the patients who received multiple prior line of TKIs, the benefit of any TKI will deteriorate very fast. If you see the 2 prior TKIs, median PFS has not reached. More than 2 prior TKIs, it is PFS is to the tune of 11 months, and 3 or more TKIs, 6.5 months. So this is somewhat like prostate cancer, which we see. If we use docetaxel and abiraterone in hormone-sensitive phase, there is a very significant benefit of the drug. While you reserve docetaxel for the CRPC setting, what happens? The PFS is only 5 to 6 months. So this is what happens with this drug also. That is why it is always tried, if feasible, to utilize the drug upfront so that you can get the most out from a beautiful drug. That is what is worth noticing. And this is the rationale, because lorlatinib can suppress most of the single ALK mutation, including the dreaded G1202R. So that is very important, and it can act in all the variant fusions as well. Let's see progression on one of the ALK TKI. If let's take a situation, the patient was on ceritinib. Rohit boss, the patient was on first line ceritinib. Now patient has progressed in brain. What will be your choice now in the second line selection? And what would you like to do, a rebiopsy? If any other site is available, what is your?
So if any other site is available, I'll go for rebiopsy and look for ALK kinase domain mutation, and to look what is the sensitivity of that mutation. And if it is CNS only progression, then we can also give a whole brain radiation and continue ceritinib if there is no progression elsewhere.
Okay. Okay.
Yeah. And definitely switching to lorlatinib is also an option if there is CNS progression only.
Okay. So one thing I would like to add here is if patient is progressing in brain only, then also we try to check for CSF. Also we do at the same time CSF cytology and cell block. CSF cell block is sometimes positive and helps in getting a tissue on which the resistant mutations can be tested. So that is one another way which we have found. Patient was having progression in the brain. We did CSF cytology and cell block. Cell block was positive. We performed kinase domain mutation analysis on the CSF block. So that is also a strategy which can be considered. If patient is only progression in the brain, other sides definitely we try to do FC. Amit Agrawal sir, again one point which when sending a NGS for such a patient, where the patient has progressed on one of the ALK TKI, what thing as a medical oncologist we should keep in mind? Which type of NGS should be specifically sent? Because here is a problem which we sometimes miss.
Basically, we understand that we have ALK dependent decision mechanism and non-ALK dependent. So we have to use a technology or methodology which can address both of them. So this is a very good slide, I think, which is very pertinent. When you are dealing with the scenario when you have only CNS metastasis, then the site of sampling cannot be the brain biopsy. It is not feasible. So CSF cytology-based liquid biopsy is not well established. So you can do an attempt, but you may fail because the cellularity is so low. How you can really comment upon what is happening in the brain and what mutation does the patient have, it's very difficult to. So success may vary. This is not a very good way as of now. But if you have a systemic failure, definitely a biopsy would be better. If you have multiple organs involved, then liquid biopsy will serve the purpose. It is a possibility that the few clones in one organ may have a ALK dependent and ALK, the other side may be ALK independent. So it is better to have a holistic approach by a liquid biopsy. So for simplistic reason, systemic relapse, single site, do a biopsy. If multiple organ involved, please do a liquid biopsy. That would be our best way actually.
So this is another point, that if there is progression on multiple sites, again, a role of liquid biopsy comes here. And now we have some approved liquid biopsy tests which are available, and that can be considered in these patients. So moving further ahead, these are the data presented at ESMO Congress 22. I would just like to highlight the red part. In lorlatinib, you see the resistant mutations, no new single ALK mutation or ALK compound mutations were found. In fact, the other mechanisms are much more common. You can see these are the bypass mechanisms, which include MAP kinase pathway, PIK3 mTOR pathway, RTK pathway, and cell cycle pathway adoration. So these are the major pathway by which resistance develops to this lorlatinib. This is analysis is a part of the CROWN trial. And if we see the PFS based on this EML4 subtype variants, it is very clear that variant 3 is also responding, but it is responding somewhat poorly, though lorlatinib appears to be best possible drug in this scenario, despite poorer outcomes. If we see this curve, this is very, very important, and we don't know where this CROWN data PFS will stop. Here we see for alectinib followed by lorlatinib, the alectinib is able to offer around 35 months of PFS followed by 5 months of lorlatinib. But again, I would like to highlight at least 20 to 30% patients will drop out because everyone is not able to receive next line of treatment because of deterioration in the performance status. Benewal sir, do you agree with this statement? Because though it seems that if we directly compare 35 months plus 5, it becomes 40, and PFS for lorlatinib is not yet reached, but we need to wait for it. But what is your take on the point patients dropping out of this PFS for alectinib plus lorlatinib?
We cannot compare directly with, we cannot add these type of graph because most of patients has a poor prognosis after progression to one line. So we have to start with best drug. We cannot add that 10 month, 9 month, and these are more than the single curve.
Yes. So that is an important point. In just pooling data from various trials and adding them and putting them in this graph in this perspective is not. Sir, you wanted to have a comment?
To avoid these side effects, can we give a drug holiday in between? Because the disease is under control.
This is a
disease under control. To avoid any side effect, can we give a drug holiday for, let's say, 2 months and then restart lorlatinib to avoid that challenge?
So definitely these are the ways and means which needs to be looked down, but we don't know till we...
See, it will be very difficult.
Yes.
So there was some question about gefitinib also earlier. So as soon as we stop it, so disease tends to progress very fast. So there is actually no point in stopping it. If the patient is tolerating it or anything.
So now the concept of MRD is coming in solid tumors.
Then you are in.
Sir, in lorlatinib case, my experience is different. One patient who was progress on serotinib, then I started lorlatinib, but patient was poorly affordable, so he just stopped the medicine and go for the some laddu and nearby some villages and stop the treatment, and then the disease progressed after 2-3 months. But he was so young that around 35-year-old. I asked him to re-challenge it. And fortunately, we got again CR. Yeah, patient was progressed, but again we got CR in the same patient. I have only 2 patients, but out of these 2 patients, this is a story of one patient. I have no much data other than this.
In TK, even after progression, we have to continue if we have no option. There are chances of flare up. Even after progression, if we have no option, then we advise that you will continue. Otherwise, we.
So because these days the concept of MRD is coming in solid tumors, so you can do the systemic, you can say by molecular responses, and if the molecular response says that it is practically a molecular CR, then you have. I'm just extrapolating the things in the future, maybe that can serve the purpose to continue to withdraw or to make a hold and reduce the total duration of the drug given to the patient actually. But that's a hypothetical, not possible. Okay, let's see.
Yeah, we need to wait for the data. Mansi ma'am, your comment on this, the point which Dr. Amit also raised, that if patient is doing well, we can hold for some time and later consider re-challenging. That means a drug holidays like
with lorlatinib.
with lorlatinib, yes.
Honestly, not very sure about treatment holidays, especially if a patient has already progressed earlier, and especially if you're targeting the intracranial this thing, because then patients, if they progress rapidly, then they don't give you a lot of time. So I've personally never really tried that. And
so definitely, I completely agree. Because the problem is that even if out of 5 patients, 1 patient progresses in that holiday, it will be a bad experience, and this might lead that, as I said, 1 patient also progressing fast, this patient might not be able to receive next treatment again. Or
in CML, after I think 7 to 8 years back in CML, we say that we cannot stop drug lifelong, but now we have some. If lorlatinib or some new drugs comes that they can do complete response, then we can think about this.
Thank you. So to conclude, in treatment naive ALK positive patient compared to crizo, there's definitely significantly larger PFS, higher overall and response rates, improved global quality of life. Safety profile is well established now. CNS adverse effects are need to watch about. Grade 3-4 adverse were more frequent, but majority were asymptomatic, readily managed. And with sequential treatment, approximately 35% patient will develop resistant mutations on lorlatinib with a solvent front, and ALK G1202R containing compound mutation becomes a common on-target resistant mechanisms, and these are actually predominantly refractory to all known ALK inhibitors at this point of time. So all these results support the utilization of lorlatinib as first-line treatment in ALK positive non-small cell lung. With this, I would like to stop here, and if there are any questions, we can take. Thank you. Thank you to the panelists. Thank you.
Thank you, sir. Thank you for a wonderful panel discussion. Now